All right, let's put on our detective hats. Today, we're diving into a clinical mystery, a puzzle that really starts with some subtle clues hidden right inside the rhythm of the heart. We are investigating mitral stenosis.
So our case kicks off with the patient's main complaint, a question that points us right to the body's engine. Why is every single breath such a struggle? This is the mystery we've got to solve.
You know, the first clues, they're the kind of things people often brush off. Just feeling tired all the time, getting winded from a simple flight of stairs, or maybe needing to prop yourself up with an extra pillow just to breathe at night. But for us, these are our first leads. And what's really interesting is that a lot of the time, something specific kicks it all off, like pregnancy or a heart rhythm issue called atrial fibrillation.
Okay, so our suspicions are up. We've heard the patient's story, but now it's time for the physical exam. And the next piece of evidence, well, it's not something you can see. It's something you have to hear. The first real concrete clue is a sound.
So with the stethoscope, we can pick up this very specific, very telling sound called an opening snap. Honestly, the best way to think about it is like a rusty door hinge. That's pretty much what's happening here. It's this sharp, high-pitched pop as a stiff, thickened mitral valve gets forced open. This is not a normal sound. It's the signature of our culprit.
And here's where it gets really cool for us detectives. The timing of that snap tells us a whole story. We listen for the second heart sound, we call it A2, and then we wait for the snap. In milder cases, there's a bit of a delay, but as things get worse, the pressure in that left atrium builds up like crazy, forcing that rusty valve to snap open way sooner after A2. So a shorter gap means more severe disease. It's a critical clue.
Listening gives us some huge clues, right? But to really build our case, to get that definitive confirmation, we need to get a look at the crime scene. We need to actually see inside the heart.
So what's in our diagnostic toolkit? Well, there are a couple of key players. An ECG can give us electrical evidence, maybe show that the left atrium is enlarged or that it's an atrial fibrillation. But the real game changer, the gold standard for this investigation, is the echocardiogram. It's basically an ultrasound of the heart. And the echo, it does way more than just confirm what we think is going on. It helps us plan our next move. We use this scoring system to check out the valve's condition, looking at 4 things: how well the leaflets move, how thick they are, if there's scarring underneath, and how much calcium is built up. Think of it like a damage assessment. A low score, like 8 or less, tells us the valve is still in pretty decent shape, maybe a good candidate for a less invasive repair.
And at the end of the day, the echo gives us a cold, hard number. A healthy mitral valve should have an opening of about 4 to 6 square centimeters. When that opening shrinks down to less than 1.5, bingo, we've got our diagnosis: significant mitral stenosis, case confirmed.
So all the evidence is in. The diagnosis is clear: mitral stenosis. But a good detective doesn't just stop there, right? We have to understand the origin story. What causes this, and how does it really mess with the heart?
Believe it or not, for the vast majority of people, the story of their mitral stenosis started years, sometimes decades earlier, with an infection called rheumatic fever. It's this inflammatory reaction, usually after something like strep throat, that can quietly cause damage to the heart valves. And even if a person has no memory of ever being sick with rheumatic fever, it's almost always the prime suspect.
So what does this rheumatic heart disease actually do to the valve? Well, it's like a multi-front assault. The leaflets themselves get thick and stiff. The corners of the valve, what we call the commissures, start to fuse together, which makes the opening smaller. The little cords that support the valve, the chordae, they get shorter and also fuse. And then, to top it all off, calcium starts to deposit on everything, turning what should be a flexible door into a rigid, narrow opening.
Okay, so we've cracked the case, we know what it is, and we know why it happened. Now, the job shifts. We need to put together a game plan, a strategy that could range from medications to control symptoms, all the way to a full-on intervention.
Now, one of the biggest curveballs in managing this condition is a very common partner in crime, atrial fibrillation, or AFib. As that left atrium works harder and harder to push blood through the tight valve, it stretches out and gets electrically unstable. The numbers are pretty staggering. Somewhere between 50 and 80% of patients will eventually develop AFib, and that hugely increases their risk of having a stroke. And because that stroke risk is so high, blood thinners are absolutely non-negotiable. But here's the thing, and this is super important. Not just any blood thinner will do. Today we have these newer drugs called DOACs, and they're used all the time. But in this specific situation, they are not recommended. A huge study called the Invictus trial showed that patients with this condition on a popular DOAC actually had a higher risk of stroke and death compared to those on the old-school drug warfarin. It's a huge reminder that sometimes the old standard is the safe standard.
So, that begs the question, when do we stop managing with pills and actually go in and fix the valve? Well, there are a few key triggers. If someone's ability to exercise starts to drop off, that's a big one. If they have an episode where their lungs fill with fluid, pulmonary edema, that's a really clear sign the heart is overwhelmed. And interestingly, even if someone feels fine, if we see that the pressures in their lungs are getting dangerously high, it's time to act.
And this really gets to the heart of it all, to the core philosophy of being a good clinician. It's this idea that while all our tests and our numbers and scores are important, they're just part of the story. The ultimate decision maker has to be the patient's symptoms and their quality of life. We're not just treating an echo report, we are treating a person.
So when it is time to intervene, what are the options? Broadly speaking, we've got two main paths. For patients with that good echo score we talked about, the ones whose valves are still somewhat flexible, we can often do a less invasive procedure called a balloon valvulopathy. We thread a catheter up and inflate a balloon right in the valve to stretch it open. But if the valve is too scarred up, too calcified, or maybe it's also leaky, then the only real solution is open heart surgery to replace the valve entirely.
And just like that, our case is closed. We followed the trail of clues from a simple complaint of breathlessness all the way to a definitive treatment plan. But you know, the story of medicine never really ends. It's always evolving. As our technology gets better and we find even less invasive ways to fix the heart, our whole detective kit is going to change. And that leaves us with one final big question. How are these new tools going to reshape our entire approach to solving the heart's deepest mysteries? Well, that's a case for another day. Thanks for joining this explainer.